Well, greetings again. This is Dr. Bill Wyatt with the American Orthodontic Society, and I'm going to try to go over this TMJ thing that I think is very important for people to know. In fact, I think if you're going to mess with teeth, everything you ought to understand the jaw joint itself, everything about it you can, and it's frequently there's nobody having a problem with it, but I want you to examine every patient you work on and see. If you just stand behind them and put your finger right here in front of the ear and you wiggle your jaw back and forth, you can feel both condyles right here and the way they work. And that's what I want to make sure that everybody that messes with the teeth understands that. In fact, just anybody out there that's having problems with it, you should understand that too, that you put your finger up in here. And then when you move your jaw forward, you'll feel the condyle move down the eminence. If you chew on the left side, you'll feel it move out of this side, the right side, and stay in over here, and you can chew with your teeth on the left side of your mouth. If you go to the right side, the same thing. This one stays in place, this one drops down. We are fabulously made, I tell you. When you know our stigma fell out here to bite together, and now the eminence is right on top. Now I'm going to show that on cadavers that have been cut down by the University of Sweden years ago. And I got their tape, and I'm going to show you that, and I can stop it and start it and show you everything about this and you can pay attention. I'm going to make it like very simple for everybody out there who knows it. And if you're an orthodontist, I hope you're one of our subscribers. I know that many of you are. So I'm going to go ahead and click this thing and start it. And I'll show you. I can stop it like that. Now this, if I go again right now, you will see the condyle move. And let me explain what's going on here. This, where I'm going around with the arrow, I can't draw these videos. So this is a video put out by the University of Sweden, and two gentlemen did it. Now this is the retrodiscal tissue back here, where your synovial fluid is formed, and also food for this portion of the jaw joint is so under such pressure when you bite out in the front that there's no nerve endings or no blood vessels in this portion of this tissue. It has no feeling to it, but this is where tremendous pressure is put on that. This portion has to be fed. Now, this is what we call a biconcave disc. In other words, it goes like this, comes up here, comes down in this area, comes around. It's shaped kind of like a donut with a covering on the inside right here. And that covering has been there. Now, I just got over my birthday. I am now 97 years old, and my joints work constantly. Whenever I chew, they open and close, and you can see that right now the mouth is partly open, your condyle is in this position right here. Now just poke it a little bit and stop it again. Now the mouth is open further. This is the head of the condyle right here. This is the eminence and the fossa sitting right there. And your ear is just really short distance up here. Now, they ask a question, how does this get hurt so bad so often? Your jaw is actually hanging on your head with fiber and ligaments and skin holding it in place. And when you move your jaw out, everybody that plays any kind of sports at all should wear some type of mouthpiece that allows that you put in your mouth when you close down and you don't bite all the way through it, and you keep it where it'll stay on the upper arch. And so when you get into some conflict deal, if you're playing ball or basketball or anything, as you get fall or hit in the jaw, you should have something in there that protects your teeth and your whole jaw joint, everything. Other than that, the jaw gets hit. In other words, I'll go down further and explain that a little more. Now I'm going to move the jaw forward a very small amount, and you'll see how. Now that's about as far forward. You saw it go out in this direction and then start back. Every time you chew, this takes place in your mouth. It is zillions of times. And now at my age of 97, I still have that tissue. It is still there. It is still in good shape. And I can open and close my mouth, and I can move my jaw from side to side. Every patient you work on, or anybody that wants help in there, just get behind them, put your finger right in front of the ear. I'm not trying to tell you orthodontists or people that are doing orthodontics, and I think you understand this, but you can put your finger there, do your jaw back and forth like this, and you can actually feel like the outside edge of this condyle as it goes around in here. And so you can tell if you have damaged this jaw. Like let me go down here a little further here. I'll go back, focus, heal. All right. Now this went up. When it went all the way, you can kind of see the fluid seep through here. Now this is a jaw joint. It's these two gentlemen in Sweden cut down on cadavers. People who donated their body to the study of the anatomy, helped, and I appreciate those people doing that. Now, the jaw's pretty much closed. I'm going to poke this again, and we'll go down. I'll stop it again. If you hit in the jaw, I was playing football or boxing or just playing hockey, any kind of thing, is you get your jaw jammed up in there and you knock this in a backward direction, you can cause this disc to be squeezed completely out of place. I'll show some of those that are out of there now. And now they pop and they open and close. Now this one is working good. Let's go again. Watch this thing work. Now right about there, your mouth is open. Now if I bite with my front teeth out here, none of my teeth touch back in here. That's the way they're supposed to work. And I'll bite something in two out here, and the pressure I put out here, it'll be twice or more back here in the back. It's like having your arm raised up out here. You can feel this ligament in your arm and you raise it, and it takes a lot more force back in this part of the arm to pull it together. If you pull with 10 pounds of force out here, you probably have 20 or 25 on each side back here, and you can pull that ligament loose. If you pull hard enough, you can tear it a little bit, and it'll be sore for about 6 months. I've done that water skiing, like that. Now, let's go on and we'll tell some more. That's how this thing gets hurt. If you get hit in the jaw and you shove this part back and you crowd this and you cause this retrodiscal tissue to be kind of damaged or hurt, and it'll swell up. Now every time you chew, you're going to have to rub this thing again. And anything that gets inflamed and sore. So if you get hit in the jaw, put some ice pack on this, keep it from swelling if you possibly can. If it does swell, you can take medications that reduce the swelling and also make it easier on this. But if you continue to close and open the jaw chewing, which if you eat anything, unless you're just drinking something, this is going to be irritated every time you open and close your mouth. And people ask, why does it hurt so much? Now, I want to tell you something else about this. If you continue to chew and move this, which you almost have to do, the pain gets desperate inside there. I've had people come in and you couldn't touch their joint up here. You know what's wrong to start with. You know they've had this damage. They've been hit, something has gone wrong, or else you've got a bite that teeth are hanging over and they can't move their jaw forward, and you keep using it, then the pain gets so bad in that area till you will feel headaches, you'll have shoulder pain, pain in your neck, all over, and many I've had patients come in and been hurting for years, really. People tell you, hurt just, and they keep doing that. My granddaughter majored in music, and she learned about the vocal cords in the mouth back here, where you're saying, and you keep, if they get inflamed and sore, and you keep using them, and just keep aggravating it and aggravating it, then they'll get this same pain, the headaches, the necks, the shoulders, everything around hurts that. And frequently for years going by, the physicians didn't realize if they had touched this joint. I had a patient who was very intelligent. She had a television program, everything, and she was suffering from that, and she had spent all of her money going to doctors, taking brain scans, everything, trying to find out what was wrong with her. If they had only touched the jaw joint right here, they could have told in a second what it was. She wouldn't let you touch it, but they didn't. They kept looking for the problem outside, and she spent just most of her money trying to get well over that. And they were going to send her off to asylum. They said, there's nothing wrong with you. And then luckily, I got to see this lady, and put my finger up here, and that was giving her trouble. And so I put her in a splint. I brought her jaw forward, and I put some space between the splint so that the condyle and the fossa didn't even touch. You had something on the split that kept it apart right here, and you had a ramp that made the teeth go in a forward direction up here. And that's all a split is. And you can make them yourself. And we made our own splits right there in the office. And I'll tell you how to do that later on. Now let's go ahead and see this thing go forward again. Now the mouth is wide open, right there. Now it's going back. Now watch it close up, and you see that fluid. When you press that tissue, it forms the synovial fluid, and it also forms the food structure that supplies this disc in here. And that has to be fantastically made and taken care of, because I'm 97 years old, and that still is in good shape right here. It's going to outlast me a long shot. And that was, I hope this answers two or three of you. I think your physician, your doctors, and you're probably orthodontist, and you wonder why it hurts. Don't work on anybody until you felt their jaw joint. I got a little girl one time who couldn't open her mouth but about 28 millimeters, and I took her as a patient, and I massaged it and worked on it, and we leveled it out, and we got her where she could open her mouth wider, and the disc in her mouth, this part was off, and it was out in front. Let me go through this, and I'll show you one that is out front in just a minute. That goes open, closes, and 2 or 3 more closes. And that's the jaw is out in this direction over here. And the teeth are out, way out here somewhere. All right, now watch this jaw. And if you start, you see that disc is worn in two right here. Now when this person opened wider, and the jaw's going back in the other direction, this portion here that's fed has been neglected or hurt and wired up there, and it died, and now there's nothing in between there. You'll get a raking sound when this kind of a bone-to-bone contact goes over that right in here. And it goes, if you've got one of these things that magnifies the sound, you put it up there and you'll hear kind of a dragging. But this amazingly doesn't hurt the person. It'll wear down, and this to be flat. It'll kind of peek out here. Now in a minute, they're going to lower this jaw down, and you can see this hole is worn out. All right. Let me see if I get this here. We're going to lower that jaw. There we go. Now, here is the outer portion. This portion out here has been cut away, but this was kind of like a donut with this tough tissue in between. And mine is still there after 97 years of eating and getting it damaged, and it healed up and everything. It is still there. It's been fed and taken care of that way. Now, as that person moves further out, I'm going to slide it a little further, and you'll see this go in. Oops, let me go back. Back it up just a little bit. Now, the edges of this are gone. I've talked to old surgeons who used to, when you broke your jaw, they wired it and you pulled that thing together and you couldn't open it for a couple of weeks, 3 or 4 weeks maybe, while the bone grew together. But this tissue in here would starve to death while you had your jaw wired together here. And you couldn't tell the difference. I've talked to old surgeons who said they've gone in there to work on this portion that was so tough, it was just like cheese. You could scratch it off. And so it's dead, it's gone. Now this bone, it's going to rub against the bone right up here. You can see that. And that'll, now here the disc is going mesily. You watch it pops off, it'll go thump, and then it'll slide back on. You take somebody whose disc is popping, if it's just on one side, their jaw will grab over here, and now it'll move back in line. In other words, it's coming off on one side. Now you can have other people, it'll pop off, it'll go on 2 sides. Both of them are off. And if you could get somebody when right after they get forced off, you can bring their jaw forward a little bit and let it, and don't let it go back over it. Now the double concave in this area, the one that slips off, it'll become flat. The double concave deal, it'll flatten out. Maybe you can see that here. See how flat that is? Now that pops, you'll hear it pop right there. I can't go slow enough. Now it's going to pop back on. In other words, somebody right here that gets up like that, and it'll go a little further, and all right, we're going to pick back up here. Now watch that disc come off now. It goes up. Now when they open, it'll go. And then it'll slide on back, and then it'll go just kind of a thump like that. So I've worked with these people with TMJ problems for about nearly 30 years. We got every one of them out of pain, but you can't handle the pulp. Now there's a doctor in Dallas, Dr. Larry Wolford, who I talked to him about it, and what he does, if he works on somebody, he'll do the double jaw surgery. He goes up and now the jaw's going out in this direction right here. He can put 2 staples in the back of the condyle right here and ties it so he's got 4 lines out here, and he goes in and sutures into this retrodiscal tissue back here and sews that so it stays on the jaw. it doesn't come off. And he has much better work doing his patients if he has tied that back properly, like that before he starts. That's the way that thing works. I'm going to show that a little more. I'm going to have to get a little drink of water here. My mouth is getting dry. Okay, this kind of covers how the joint works, how it wears out, or it has a hole cut in it because it was tied up, or for some reason it loses the food and it'll starve to death. And now this jaw will get a kind of a peaked out position. Let me follow that one. Let's go in the other direction now. You see how flat that's got. And I thank these gentlemen from the University of Sweden that have shown that. And I have shown it to thousands of people how it can work. And I owe them a debt that it's off like that. I don't know whether there's, I think at the end of this, maybe they show when it has nothing up there. All right, here is one where the thing is completely gone. Now the condyle takes a flat, and the eminence gets a flat deal. And it wears down like that. Now this normally doesn't hurt the person, but it'll make a noise when it comes back and forth. And it just slides like that. And I've had people, I had a lady one time, it was popping, and I didn't see her again for 10 years. She came back in, and I x-rayed it, and her jaw had beaked out like this. Now it's got something in between, but not the regular disc tissue. And it's almost like bone-to-bone contact in there. You see it's going back and forth. Now here's one that is really worn out. Look at that. This is a piece of the disc back here. Here's the other piece. Now this is the one that doesn't hurt. The other one was used as a part of the ligament in front here to slide rather than the thick part of the double concave. It goes back and forth like that. Now that is the end of that deal. I'll slide back down here and show you that a little more. That's the end of it. This is as bad as they get. And this will stay that way as long as they live. And they'll have a kind of a grating noise when they chew. But this really doesn't hurt the person very much. The one that I could tell didn't hurt them. And it's going to be that way, and you can't change it. Now, if you put a crown on somebody with an on, and then that comes off, then this thing's going to be in the air, and that crown won't fit right. So you really need to tie that back if you can get it on there, if you're going to crown or two or do any kind of work there. So I'm going to close this out, and I'm going to say thank you for watching, and I hope you get something from this, learning what this actually does. In this video, you can get it, you can probably get it from the University of Sweden. But anyway, you can take these videos we have and use this and show you about that. So I'm going to hush up for the time being, and we will try to cover another thing about the temporal mandibular joint. And I think everybody working on people's teeth should understand this and talk to the people if they have a problem. Try to learn how to do a split. It's not all that complicated. And I did that for people for years. And we got everybody out of trouble. And we had we advanced their mandible, and I was doing that for TMJ work, and then finally decided to advance the mandible just for aesthetic purposes. And I'll try to show a case where we did that also. So I'm going to close out and say goodbye for the day. And I'll come back later on.